Good morning, everyone. Today I'm going to talk about multiple sclerosis. I chose this topic because of the amount of patients we see with symptoms suggesting of MS or patients with diagnosis of MS during the rotation. Well, as an introduction, this is the most common immune-mediated inflammatory disease in young people, and it usually presents with multifocal areas of demyelination and loss of oligodendrocytes. Epidemiology. Well, the age of onset for this disease is usually between the 20 to 30 years old, specifically 29 years to 30 years old. And the peak of onset is usually earlier for women than men, usually 5 years earlier. The amount of patients with MS that present with the first symptom before 18 years old is usually 5%. And 3 to 12% of patients present with the first symptoms, usually after age 50 years old. The sex distribution, as I mentioned before, is usually more frequent in women and earlier in women than in men. This probably may due to the childbearing patterns, epigenetic factors, and environmental factors. The ratio is usually 2 to 3 to 1. From women to men in most of the countries where this disease presents. The mortality, well, usually it's very rare for people to die due to a relapse of MS, but it was found that the median survival after the diagnosis for men was 20 years old and for women was 33 years old, compared of 42 years old for the general population in this study. But with the introduction of disease-modifying therapy, that I will talk about later on the presentation, this survival of patients with this disease can be prolonged. Well, the geographical distribution. The prevalence of MS in 2016 was around 2.2 million of patients around the world. It is usually most common in North America, specifically Northern United States and Southern Canada, where the prevalence can reach about 100 per 100,000 people. And is usually frequent in Europe too, and some parts of Australia. But during the last 25 years, it was found that in Canada, there was an upsurge of cases in 82%. The pathophysiology. Well, the pathophysiology of this disease includes changes in axonal conduction with the demyelination. Well, the myelin is usually a protein, a lipid-rich protein that provides insulation for the electrical impulses so they can flow in a saltatory fashion. As we can see in this image, in the top part of the image is usually how the current flow must go in a saltatory fashion from node of Rambier to node of Rambier. But in the lower part of the image, we can see that the myelin is disrupted, so the current flow cannot go normally in this axon. So the demyelination usually interrupts the current flow by removing this function of insulation of myelin. Well, it's important to know the formation of the multiple sclerosis lesion too. It's usually the activation of myelin-specific T cells that in the periphery that precedes the formation of this lesion. That's usually a plaque. One of the earliest features of this interruption is the disruption of the blood-brain barrier. That is usually the one that is in charge of the protein transport and ion concentration in the central nervous system. During a relapse of MS in patients, activated CD4 T cells are likely the first cells to enter the central nervous system, followed by autoimmune cells. Usually, the growthly pathological hallmark of this disease is a plaque. As we can see here in this image, usually the distribution of the plaque is very ventricular. We can see lesions over here in this image of a brain. Usually the individual lesions are small. They're usually 1 to 2 centimeters, but may become confluent and form a larger plaque. These lesions can be found all over the central nervous system, including brain, spinal cord, cerebellum, and brainstem. When they are new plaques, they're usually pink or whitish, but when they are old plaques, they usually have a grayish discoloration. Well, histologically, we can see here an image of an older plaque. We have that older plaques usually have sharp delimitations. We can see here the absence of myelin compared to myelin found here around the plaque. When the myelin is disrupted, it can be found in clumps of foamy macrophages. And in these plaques, we can also find immune cells, basically lymphocytes that are sensitized to myelin antigens, specifically myelin basic protein. That's the main one for this disease. And other immune cells and other cells from the central nervous system, like microglial cells, endothelial cells, and astrocytes, can be induced to express major histocompatibility complex and function as antigen-presenting cells. Here we can see another image of histology where we can see an old plaque that also has sharply margins. We can see a presence of myelin here, absence of myelin over here. Well, activated T cells and microglia can also contribute to the cell injury by other mechanisms. They can express soluble factors like cytokines. The main ones are interleukin-2, interferon gamma, and tumor necrosis factor. This can cause a shift towards Th1 cells expressing these soluble factors that contribute to the migration of other immune cells and tissue injury. B cells and immunoglobulins are also found in these lesions. Well, we're going to go with the etiology. There are a lot of theories that are talked about the etiology of MS. One of these is autoimmunity. This involves a lot of molecular mimicry. It's thought that several viral and bacterial peptides share structural similarities with the myelin basic protein, and this can activate specific T cells. That the central nervous system infection is also another theory that can cause tissue damage and antigen release to the peripheral circulation, activating these T cells. Also, we have to talk about genetics. There is a high frequency of familial occurrence in a non-Mendelian inheritance. For example, there has been a lot of studies in twins. It has been found that monozygotic twins have a higher risk of having MS in about 30%. Dizygotic twins have been found to have a lower risk, about 2 to 5%. And it has been found that siblings have 30 to 50% more risk of having MS than the general population. It is also associated with major histocompatibility complex and specifically associated with HLA-DRB1501 allele. Well, infections have been associated to the pathogenesis of MS2, specifically human herpes virus, number 6, Epstein-Barr virus, and chlamydia pneumoniae. Of these pathogens, the most associated have been Epstein-Barr virus in a prevalence of 99% of patients with multiple sclerosis compared to a 90% in general population. Also, a history of infectious mononucleosis have predisposed to MS2. The potential mechanism for this disease is inappropriate reactive immune response and a direct role of the virus in promoting inflammation. Vitamin D has also been associated, especially in lower levels of vitamin D. This increased the prevalence of multiple sclerosis, and it has been seen in places that are farther from the equator, as we could see in the geographical distribution. Also, it has been seen that vitamin D supplementation was inversely related to the risk of having MS. Smoking is a risk also for having MS. Smokers have a more severe course than non-smokers in this disease, and it's thought to be also a neurotoxin and an immunomodulator that promotes inflammation, just as Epstein-Barr virus. Well, the characteristic clinical symptoms of this disease, the presentation is very variable, but we have a cranial nerve dysfunction. We're going to start with impairment of visual pathways. One of the most frequent presenting symptoms of this disease is optic neuritis. It can present in an acute or subacute unilateral form. It's really rare that it presents bilaterally. It's not frequent in MS, but when it does, it's usually the first appearance is in one eye, then the other eye can be involved, but it's really rare. Patients also present a variable degree of visual loss affecting the central vision. They can present with central scotomas, as we can see in the image on the right. Patients can also present with Marcus Cumb papille, and most of the patients, around 90% of patients, regain normal function after the attack, usually 2 to 6 months later. We also have impairment of ocular motor pathways, but is less common. The involved nerves can be the 4th, 3rd, and 6th nerve. Patients present usually with the nystagmus, and they complain a lot about oscillopsia, that is a subjective oscillation of objects in the visual field. Also, we can see ocular pursuit movements that are saccadic when we are examining these patients. The impairment of other cranial nerves is usually not common, but when it's present, they have impairment of facial sensation. They can present with trigeminal neuralgia, but that's usually later on the disease of the course of the disease, sorry. They can also present as facial myochemia, that are undulating movements or contractions of the facial muscles. They can present with unilateral paresis or hearing loss, but is infrequent. But most patients present with 30 to 50% of cases with vertigo. They can also have impairment of cerebellar pathways. The most common presentation is intentional tremor of the limbs, and it can be so severe that it can interfere with daily activities of the patient. And there can also be gait imbalance, impairment, and alterations of speech. The impairment of sensory pathways is common. It's usually present at some point during the course of the disease of these patients. It can present with numbness, tingling, pins, or needle sensation. It's also very common to find a pain-like abdominal sensation that's characteristic of MS-HAC, and impairment in all sensory modalities like vibration, joint position sense, pain, and light touch. There can also be impairment of the motor pathways. Patients present with paresis or paraplegia, usually in the lower limbs, is the most frequent presentation. There can also be hemiparesis, but usually it disperses the face, and spasticity is so severe that it can lead to joint contractures. It's uncommon, but patients can usually present also with amyotrophy of the muscles of the hands, as we can see in this image. Patients can also present with bladder, bowel, and sexual dysfunction. The bladder dysfunction is usually incontinence. It's usually in the disease presents with urgency, but later on the disease, they can present with overflow, the incontinence, because they lose the ability to feel the fullness of the bladder. This can lead usually to urinary tract infections in these patients. They also present with constipation. This can be due to a lot of factors. They can be a decreased mobility of these patients due to the other symptoms. It can be decrease of the intake of water due to the urinary incontinence that can lead to this condition. Sexual dysfunction is also very common in this patient. It's actually reached the 40 to 80% of patients. In men, there is usually erectile dysfunction, and in women, it usually presents as decreased libido or lack of orgasm during the sexual relations. Well, the diagnosis of this disease. For the diagnosis, we have this criteria, the McDonald criteria, that was proposed first in 1991, but lastly was modified or revised in 2017. During this last revision, the addition was that we can use a cerebrospinal fluid evaluation, obtaining oligoclonal bands for the diagnosis of multiple sclerosis. This has three criteria, for example, clinical attacks, lesions, and additional criteria to make the diagnosis. In the first case, for example, we have 2 or more clinical attacks. And if we have an objective clinical evidence of 2 lesions, we don't need any additional criteria to make the diagnosis. But for example, if we only have 1 clinical attack and objective clinical evidence of 2 lesions, we would need a dissemination in time or wait for another clinical attack to make the diagnosis. We can also use a cerebrospinal fluid evaluation, obtaining oligoclonal bands to make the diagnosis. We also have imaging with magnetic resonance imaging. We can see that the lesions for MS are usually located in a periventricular distribution. They are oval in shape, and they can enhance in T1 weighted images when using contrast, mostly gadolinium. This indicates that the plaque is usually active, as we can see here, or is a new plaque. If it is hyperintense in T2 weighted images, like we can see here, usually means an active plaque. And we can also see sagittal images, as this one, the letter C, sorry, that when the lesion forms a right angle with the carpon callosum, is usually known as dozen fingers. And these lesions can be found in any part of the central nervous system, as we can see here, brain, brainstem, cerebellum, or even spinal cord. We can see on the images on the right. Additional tests for making the diagnosis. Well, the oligoclonal bands, as we saw, they're part of the McDonald criteria. Well, it is a qualitative assessment where usually oligoclonal bands are found in the cerebrospinal fluid compared with the plasma. We can see here a normal study where there are absent oligoclonal bands, and here an abnormal study where they are present. They are usually present in 95% of patients with multiple sclerosis, and the finding of these bands lead us to a positive test. We also have additional tests that are not usually used, but can help us when we cannot find the structural place of the lesion. They are the evoked potentials. The 3 most frequent are visual somatosensory evoked potentials, visual evoked responses, and brainstem auditory potentials. We have the optical coherence tomography. That's an additional test too. Is not required to make the diagnosis. This usually is used for optic neuritis. It uses infrared light waves that reflect the structure of the retina. As we can see here, it obtains an image and is usually reduced in 85% of patients. Well, the differential diagnosis for MS is usually very wide due to the variety of symptoms they have. The range goes from inflammatory diseases, infectious diseases, genetic diseases, even diseases such as low vitamin B12. So I think the important thing about differential diagnosis is to recognize the red flags that would lead us to another disease that is not MS. Some of the most important ones are, for example, family history of neurologic disease other than multiple sclerosis, non-specific symptoms related to the central nervous system, for example, fatigue, non-specific fatigue, hyperacute presentation or short-lasting symptoms that goes from minutes to hours in presentation and in lasting, meningeal disease, headaches, encephalopathy, and any other neurologic symptom that doesn't remit. For example, optic neuritis that doesn't have remissions or that are severe in presentation. As I said before, also bilateral optic neuritis is very rare in multiple sclerosis, so it can lead us to think of other diseases. And symptoms that usually indicate systemic disease, such as weight loss, fever, and night sweats. Well, we have different clinical phenotypes of MS that are important to mention. The first one and most common is the relapsing remitting. These are attacks that usually, as we see here, they are unpredictable and they have periods of remission like this and periods of relapse during the disease course. The secondary progressive presents initially as a relapsing remitting disease, as we can see here, but it usually has a decline in the presentation of the patient that is steady. The primary progressive disease usually is a gradual progression without these periods of relapsing and remitted, as we've seen before. The progressive relapsive one is the one that has a steady decline, but also has superimposed attacks. And isolated syndromes is important to mention these syndromes is usually the radiographical one and clinically. The radiographically are asymptomatic patients that usually get an imaging study for any other reasons. It can be such things as accidents or headaches. And that's when they are found to have lesions corresponding to MS. Clinically isolated syndrome is usually patients that present with a symptom that is suggestive of MS, but the MRI does not meet the criteria for dissemination in time or dissemination in space. The variants of MS, we have a tumefactive variant that we can see here. It usually presents with large lesions, larger than 2 centimeters or confluent lesions in one hemisphere, and these usually have a space occupying lesion, as we can see here, is compromising the right ventricle. The clinical presentation is very variable because it has this mass effect and is usually diagnosed with biopsy. We have the Marburg variant that is really uncommon and it has a fulminant course. It also has these confluent lesions on the hemispheres and also has a mass effect on the midline of the brain. And here you can see the ventricle, the right ventricle is compromised. It's usually very variable in the presentation too. It can include seizures, motor and sensory deficits, and aphasia. The pathology can reveal confluent demyelinating lesions, and it usually has a very poor prognosis. We have the Balo concentric multiple sclerosis that sometimes is not considered a part of MS, but others consider it a variant of MS, so we're going to talk about this one. Well, in the pathology, we found usually alternating rings of myelination and demyelination, and we can see is characteristic in the imaging, concentric rings that enhance in T2 weighted images. And they usually enhance in T1 weighted images too, with a contrast of gadolinium. The symptoms are usually the same as the last ones we have seen, with space occupying symptoms. And it usually has a good prognosis. Before it was thought it had a bad prognosis, but it was because it was diagnosed only when doing autopsies. Now, treatment of MS. Well, the indications for treatment are usually when the patient have disabling symptoms that interfere with the daily activities of the patient, but mild attacks can also be treated for symptom release with analgesics and glucocorticoid treatment. Well, the main goal is to decrease the severity of the disease and speed the recovery time. And patients can be, when they have an active disease, they can be offered disease-modifying therapy. The initial treatment with glucocorticoids are usually at high doses and short-term. Before starting this therapy, we usually need to rule out or exclude any particular infection, mostly urinary tract infections. We can use the intravenous form or oral form. For the intravenous form, we have the methylprednisone, and for the oral form, we have the prednisone. It's usually given in a dose of 1,000 milligrams daily, usually for a short period of 5 days. The treatment for refractory relapse is usually for patients that have a poor response to the medications, and is usually given with plasma exchange and immunoabsorption. Plasma exchange usually removes non-selectively proteins from the plasma of the patient and is given daily or every other day for a total of 3 to 7 lesions. And immunoabsorption specifically removes circulating autoantibodies or immunoglobulins. The problem with this treatment is usually that it has a very high cost and is not accessible to everyone. That's why it's only used for severe cases or refractory cases. Well, disease-modifying therapy is really a wide topic. We have here the most important medications that includes the monoclonal antibody, the oral therapy, and platform injections. What we need to know about this is that they are usually used for the decreasing the relapses of the disease and decreasing the disease progression and severity. With monoclonal antibody, it's important to know that all of these medications increase the risk for infection. For example, natalizumab usually increase the risk of reactivation of GC virus, leading to multifocal leukoencephalopathy. So we need to be aware of that. And some other of these monoclonal antibodies usually increase the risk of reactivation of hepatitis B virus. For the oral treatment, it's important to know that the sphingosine 1-phosphate receptor modulators usually are contraindicated in patients that have cardiovascular disease, usually patients that have had a recent stroke, a myocardial infarction, or that have angina. And for the platform injection, it's important to know that interferons may be associated with liver damage. Symptomatic treatment. Well, usually for the gait and involuntary dysfunction, there's no pharmacologic treatment specifically. One of the medications mentioned are dalfampridine that can be useful, that is a potassium channel blocker, but mainly this treatment is with non-pharmacologic approaches like physical rehab, bracing, assistive devices to minimize the risk of falling of the patients. Well, fatigue, the initial treatment should be an evaluation of other risk factors for fatigue, including sleep habits. But when the main symptom is fatigue and it's not due to another causes, we can use amantadine 100 milligrams twice a day, or another stimulant such as modafinil, armodafinil, methylphenidate, amongst others. Well, for cognitive impairment, there's also non-pharmacologic treatment because it affects mainly memory, attention, and speed of information processing. It's usually treated with cognitive behavioral therapy, family therapy, individual counseling, and it can lead also to accommodations at the job of the patients. Well, for mood and affective disorders, the most frequent one that MS patients present is depression. They have a risk of 50% of having depression and have suicide rates higher than the general populations. The main choice of pharmacologic treatment for these patients is SSRIs, but we can use another antidepressants depending on the symptoms that the patient presents. For example, duloxetine can be used when the patients present depression and also pain related to MS. For the spasticity, we can use also rehabilitation therapy with exercise or pull therapy, but also baclofen has been really effective to relieve spasms. It can be used in a dose of 20 to 120 milligrams. For bladder dysfunction, first of all, we have the non-pharmacologic treatment, that is fluid management and time voiding. Patients can also use intermittent catheterization when they have overflowing continence done by the patients. We can also use a pharmacologic treatment like oxybutynin, desmopressin at bedtime, and is used botulinum injections for refractory cases. For sexual dysfunction that was very common in patients, in 40 to 80% of patients, we can also have therapy, pelvic floor muscles rehabilitations or exercises. And for men that present with erectile dysfunction, we can use sildenafil, but we have to be aware in patients that have cardiovascular diseases. And it can also be addressed with therapy for all these patients. And this concludes my presentation. Thank you very much for your attention.